Well, Professor McFarlane, thank you for taking some time to chat with us. You've been a central player in trying to understand trauma in children and its long-term effects. So perhaps you could begin by telling us a little bit about this epidemiologic long-term work that you've done, and then we can talk a little bit about causes and perhaps treatment.
The study that I have just completed followed up a population of 800 primary school children who we studied back in 1983, and we also had a population of 700 kids who weren't exposed to this major bushfire, which is very similar to the fires that are happening in Greece at the moment. And we followed them up 21 years later. And it has really been very edifying because, first of all, the amount of trauma that we found within this community that was unrelated to the bushfire was an important finding. I think we often underestimate the prevalence of bad things that happen to people. People don't like talking about it.
So there was a baseline high level of traumatic experience, plus then the bushfire added to that.
That's correct. So we had one population where we had this defined event where they'd all been through it, but then the other group had motor vehicle accidents, seen serious injuries to people, and in fact 21 of the people who we originally studied had died by their mid-20s. So, and that is a measure of, and that was by suicide and violence. And the important thing that we found was that, quite surprising to me, I thought that post-traumatic stress disorder was going to be different in the two groups. It wasn't. And the reason was because there was so much trauma in the control population. What we found was that the more traumatic experiences that you have, the more likely you are to get any disorder, whether it be depression, whether it be anxiety disorders, whether it be post-traumatic stress disorder. If you've never had a traumatic event compared with 4 or more traumatic events, you increase your risk of depression in your life by in the order of 5 times.
Now, perhaps as a provocative question, how do we know that the people who are at risk for depression aren't more likely to get trauma rather than trauma creating risk for depression? How do we know the direction of the causality?
Well, I think, again, that's a very important question. And one of the issues that we were able to do, for example, was to look at how the childhood symptoms, which in a sense is an early marker of that risk, predicts adult symptoms. And we find that, yes, it does, but that is only really one factor. And the important thing is that once you've had one traumatic experience, other traumatic experiences happen. For example, the disaster-affected group were more likely to have been sexually abused, and then the women were more likely to have been raped. So it's almost like one bad thing breaks down barriers within communities that then changes the behaviour of those children and their ability to manage their movement through adolescence and managing their personal relationships.
Now, these are a number of powerful suggestions. One about the high prevalence of traumatic experience in childhood, but the second about both the impact on individuals as well as communities. So is it your view that these things interact with one another to create the vulnerability?
Absolutely, and I think, we can think about this as clinicians and we can think about it from a public health point of view. From the clinical point of view, one of the things that I've learned is that clinicians just do not ask patients in enough detail about the traumatic experiences that they've had. And one other thing that we've, in another study, found is that trauma to mothers, which the children are not exposed to, also impacts upon the children. So as a child psychiatrist or psychologist, you actually have to ask the mothers about trauma. I think from a public health perspective, if you were going to try and do one thing, it doesn't matter what sort of trauma you're talking about. If it's a public campaign to minimise the consequences of motor vehicle accidents, that's an important issue. If it's an intervention to deal with interpersonal violence, that's an important intervention. So that, I think we need to wear 2 hats in trying to deal with these questions.
Now, given the complexity of interactions between a variety of environmental factors, surely some biological vulnerability must play a role here. And how does the biological vulnerability and then the cascade, if you will, from that lead to trauma? In short, what's our biological understanding of what's transpiring?
Well, look, I think, again, that's a very important question. And obviously, there's been some very interesting work, for example, in New Zealand with the serotonin transporter gene, which shows that particular genotypes create the risk in particular individuals, or greater risk in individuals to the effects of stress. One of the other things that we've been particularly interested in is what trauma does to brain functioning. And what it really shows, and we've the problem here is that most of the studies are adults because it's difficult to do neuroimaging studies in kids because it asks a lot of them. But we've been able to show, for example, that in a population study of 740 adults, that childhood trauma changes the pattern of your brain EEG stability. In certain, the beta and the theta bands get disrupted by childhood exposure, quite independent of symptoms. So, trauma's bad for you and for your brain.
So, and what are the implications of these changes in beta and theta activity in the brain? How might that in and of itself alter the adaptive functioning in the individual?
Well, we know that beta is related to selective memory and attention, and we've done a number of fMRI and multi-channel EEG studies looking at that. And what we can show is that people with post-traumatic stress disorder have difficulty even managing relatively simple attentional tasks. And they recruit areas of activation that most people would only use for more demanding tasks. So it's a bit like dealing with their environment at a low grade. They've got their foot flat down on the accelerator. If they get an increased demand, they've got no gas left in the tank to extract more effort. And I think one of the things that we've often perhaps not thought enough about with kids is how these sorts of attentional problems that we associate with ADHD may in fact be clinical markers of the impact of traumatic experiences that these children have been exposed to but haven't been registered or documented.
It's an interesting sort of juxtaposition. In one sense, we see people who have been traumatized as being hypervigilant with regard to the traumatic event, but then what you're suggesting is with regard to everything else in their life, they may be much less vigilant, and presumably if they're less vigilant, they're more likely to have accidents, injuries, and get into traumatic situations.
Well, it's an interesting question about whether they're less vigilant to the other things in their environment or whether they're more vigilant, because if you can't attend, if you can't focus, you feel confused, so you actually scan your environment more strenuously. So there's actually a paradoxical effect. I think we often presume that anxiety creates difficulties with attending and focusing. Whereas my view, in fact, is that I think if you can't attend, you don't automatically focus. And you're scanning your environment all the time. And one of the things that we know about these people with PTSD is that they actually have difficulty in processing targets differently from distractors. I mean, healthy brain function automatically extracts the information out of what's relevant.
Right.
And they lock onto it with no effort.
But with people who've been traumatized, their ability to separate important from unimportant becomes confounded.
That's correct.
When people with anxiety disorders, and some argue that PTSD is not really an anxiety disorder, the tendency when you're overwhelmed is to withdraw. Do we see the same thing in patients with PTSD?
Yes, very much so. And I think that's one of the important reasons why sometimes the importance of trauma doesn't get recognised. I mean, part of the response in some people is numbing. So you see this person who is seemingly unreactive. They're not as overtly distressed as everybody imagines they might be. But really, they're almost sort of in this frozen, unreactive state. And the other thing is they become extremely adept at avoidance. So you can ask them about a traumatic experience, and it's almost like they have one version of the story that distracts the listener.
So until you really properly ask the questions and explore the event, you really don't know.
You don't know.
Now, what are the implications, if there are any at this moment, for these incredible bits of work you've done with epidemiology and long-term follow-up and then neurophysiologic measures? What are the implications of all that for intervention?
Look, I think the first issue is that I think when it comes to biological treatments, there hasn't been enough work done at thinking about the primary mechanisms. The pharmaceutical industry has been interested in depression and other anxiety disorders. And the interesting thing is I think there's a very specific stress physiology that you can measure in animal models. And I would really hope that somebody could begin to think about these conditions as a separate set of conditions. In terms of other clinical interventions, one of the things that I think people underestimate is the importance of the memory of the trauma and the way that sits in a person's mind and how it drives all sorts of symptomatic distress. And I think one of the things the lessons that I sort of carry in my heart from having worked in this field is the importance of how you ask people about it and not being distracted by them. And it's, in a sense, it's not what actually happened to them. Because I think often people, clinicians, almost become voyeuristic about the event. Whereas in some ways the event of itself is not important. The issue is how is it etched in the person's mind? How does it stay with them? And what exists in their environment today that they react to? And I think if there was one sort of take-home message for clinicians, it's to really find out, well, what are the things that people find themselves thinking about when their attention is undirected? What do they find themselves dreaming about?
Now, you mentioned briefly about the serotonin transporter, the long and short alleles. How does that have implications here, and for both causality and treatment?
Well, again, I think we haven't done that work in PTSD. There are a number of very interesting studies currently being conducted, but one very practical example is that in groups like emergency service personnel, if you've got two short alleles, I wouldn't be putting you in part of the tactical response team. Now, you might be perfectly suited for the job, you might have all the attributes. However, I would predict that you're at significantly greater risk of having an adverse mental outcome. You might be an extremely good police officer, but you can go and do something that isn't going to confront you with the same degree of stress.
So you choose the long longs.
I'd choose the long longs. And I think, look, maintaining capability in military forces and I think police forces is a very, very real issue. And, I think the whole foreseeability argument is going to come into play here. We can predict there are going to be groups at risk, and I think we have a duty of care. Now, people in the military environment don't want to do it because they're potentially going to lose half of their people.
I want to come back to one thing you said before, perhaps as we think about closing here. You talked about in your heart you feel things about your patients and the disorder. I've been struck by the folks with whom we've spoken with regard to PTSD. There's a lot of their own emotion invested in this. How have you found that to be for yourself?
Well, look, I must admit, I find it a privilege to work in this field because it does bring you, very close to all sorts of issues that are not just sitting in a room with a patient. For example, after the bushfires, one of the reasons why I got involved with this community was my brother is a farmer and he was involved in providing the disaster relief. Many of my relatives are farmers. It was a farming community that was affected. So, this was, I guess, a different way of really being involved at a personal level, with a community. I think, you get interested in these things because partly, you're drawn to that sort of world. In fact, when I was 16, my mother was seriously ill, and I think that when I went into medical school, somehow opened my mind to human suffering. And it's, in a way, it's a privilege. The other side of it is that there are not many areas of medicine or psychiatry that are so reflected in literature and art. And often, I think, great writers can say things that, as academics, we never see. So, it's also a privilege to be able to work in a field where you can read literature and it can enrich your sort of understandings by really taking, very primary observations that I think so often, modern research is rather immune to.
I think you're probably a very good example of how one can combine keen intellect and passion to make a real difference in the world. And thank you very much for doing that. Thank you for today.
It's a privilege. Thank you very much for your comments.